The client, David Keegan, is 78 years old. He experienced an embolic stroke 8 months ago at a family gathering. David has other medical conditions including type 2 diabetes, hypertension, depression, and osteoarthritis. David's risk factors for cardiovascular disease include type 2 diabetes, hypertension, his BMI, triglycerides, and cholesterol levels. Depression has also been found to have links with cardiovascular disease, possibly due to the changed lifestyle factors associated with depression. Health concerns for this client include recurrent stroke, decreased quality of life due to stroke effects, cardiovascular disease, and type 2 diabetes progression. Exercise greatly benefits health outcomes in stroke patients. Exercise decreases risk of mortality and risk of comorbid diseases while improving physical functioning. One of the main benefits of exercise in stroke patients seen throughout the available literature is improvement of activities of daily living. Aerobic training in stroke patients has been shown to increase maximum oxygen uptake, walking speed, and walking capacity. Stroke-specific health outcomes including cognition, arm recovery, and function, fatigue, balance, gait, and mobility have all shown improvements through exercise programs. Exercise can also improve body composition and decrease the risk of cardiovascular disease and improve blood lipids, glucose utilization, and blood pressure. Two other allied health professionals that could contribute to this client's care are a psychologist and a dietitian. David was diagnosed with generalized anxiety in 2006 and has begun experiencing depressive symptoms again due to his lengthy recovery and decreased functional ability. A study has shown that one-on-one positive therapy sessions decrease depressive symptoms in clients with diagnosed depression. Psychology sessions may also be beneficial to David's wife. Carers of stroke victims often need extra support as their lives are greatly impacted by the stroke as well. Overall, psychology sessions would greatly benefit David's treatment by decreasing his depressive symptoms and also giving his wife extra support to care for him. A dietitian will also benefit the health outcomes of this client. The client has uncontrolled type 2 diabetes with HbA1c levels of 8.7%. Diet control is a way which has been shown to improve type 2 diabetes outcomes. Control of diet with the help of a dietitian can improve blood glucose and HbA1c levels down to target levels in type 2 diabetic patients. Weight loss through a healthy eating program guided by a dietitian has also been shown to decrease the risk of coronary heart disease morbidity in obese populations. A major risk for this client participating in exercise is his falls risk. The client has stated that since his stroke he has impaired balance and strength and has fallen twice in the past 3 months. Strategies to reduce the risk of a fall occurring during exercise is to initially complete a falls risk assessment, including a timed up and go test and a Berg balance test. These results are reliable in predicting the risk of falling in elderly populations. Other recommendations to reduce the risk of this client having a fall during a session is to remove hazards and have a mobility aid ready. Eliminating hazards in an environment, including making sure there are no cords, exercise equipment, or furniture in the pathways of this client. Having the client's support item readily available in case he loses his balance could prevent a fall. The client may prefer a walker, walking stick, or possibly a wheelchair. This client is also at risk of a cardiovascular event during exercise. Intense exercise can cause cardiovascular events in those susceptible with risk factors of cardiovascular disease. While the client cannot initially complete a submaximal aerobic assessment due to only being able to ambulate for a period of 25 meters, any aerobic work undertaken by this client will include close monitoring of objective and subjective measures including blood pressure, heart rate, and rating of perceived exertion. The physical tests completed by this client include a timed up and go test, Berg balance scale, lower body strength assessment with handheld dynamometer, and upper body strength assessment with a handheld dynamometer. Completed was a timed up and go test. This test is assessed on the time it takes the participant to rise from their chair, walk 3 meters, turn around, return to the chair, and sit down. This is a quick test to evaluate the client's functional ability. The results from this test can be used in evaluating this client's falls risk and can be used as baseline measures to compare to during the exercise intervention. The client completed the time up and go test in 12 seconds and took 14 steps. This can be compared with a study who used an elderly population who have had a recent fall. The elderly population completed it in an average of 8.23 seconds with an average of 12.8 steps. This shows that the client is below the normal values for the elderly population who have had a recent fall and shows that he is further at a great risk of falling. The Berg Balance Scale was the second test used. This test assesses 14 different tasks completed by the participant to give an overall score, which can be used in determining risk of falls. For each item, a score of 0 is given if the participant is unable to complete the task. A score of 4 is given if the participant complete the task meeting all criteria. The maximum score is 56. This test can also pinpoint the actions that the participant does not have the appropriate balance and strength in completing. The client completed the Berg Balance Scale assessment and scored 38. This can be compared to healthy males of his age bracket and stroke patients. It shows that the client is under average for the healthy males in his age bracket who scored 54, and he is just under the stroke patient's average of 43. The third test is a lower body strength test using a handheld dynamometer. This test assesses the strength in hip flexion, extension, and abduction, and knee flexion and extension. The client showed lack of strength of the lower extremity in all movements assessed. However, the hip flexion and extension measures were extremely under the expected data. The final test completed was an upper body strength test using a handheld dynamometer. Upper body strength was measured using shoulder flexion, shoulder abduction, elbow flexion, and elbow extension. Results in this upper body strength test can be compared to other stroke patients in the literature when combining the shoulder flexion, shoulder abduction, elbow flexion, and elbow extension scores in kilograms. It shows that in the affected arm, the client was 15.5 kilograms, whereas stroke patients, the average was 19. In the non-affected arm, the client was 22.8 kilograms, while the other stroke patients were 29.46. It shows that the client is under the strength values in both arms compared to other stroke patients. However, the other stroke patients were not defined to an age bracket. After the findings in the initial consultation and the physical exercise testing, 3 priorities for exercise have been determined: to improve balance, improve overall strength, and improve body composition. Goals have been developed around the priority of improving balance. The short-term goal is to complete all balance exercises within the training programs for the first week of the program. The long-term goal is to improve the Berg Balance score by 5 points within the next 6 months. Developed around the exercise priority of improving general strength. The short-term goal is to complete 2 unsupervised and 1 supervised resistance training program sessions within the first week of the program. The long-term goal is to improve all upper body and lower body handheld dynamometer strength readings by 10% within the next 6 months. Established for the improved body composition priority for exercise. The short-term goal is to book and attend an appointment with a dietitian within the next 2 weeks to develop a healthy eating plan. The long-term goal is to improve BMI by 5 kilograms per meter square within the next 6 months by following the exercise program. The periodization principle is implemented into this 8-week training program to reduce fatigue and increase strength and performance. This program includes 2 macrocycles of 4 weeks. Each 4-week macrocycle builds in repetitions for the first 3 weeks, and then repetitions and sessions are reduced for a final deloading week in each macrocycle. Each week, excluding the deloading week, there are 2 home resistance training sessions and 1 supervised gym session. Stationary pedaling is 5 minutes, 2 times a day, 5 days per week during each week, except for the deloading week, which is 5 minutes, 2 times a day, 3 days a week. The upper body resistance training program is designed to be a safe, easy program that the client can complete at home unsupervised. Resistance training of the upper limb has been shown to improve strength, dexterity, and functional ability post-stroke. This program increases overall upper body strength of all major muscle groups and includes resistance banded rows, resistance banded shoulder abduction, resistance banded shoulder flexion, resistance banded chest press, resistance band pull apart, and dumbbell bicep curls. The lower body resistance training program has been designed to promote strength in the lower limb by completing exercises that also promote ability to complete activities of daily living. This program includes sit-to-stands, knee extensions, knee flexions, and a 10-meter walk. Repetitive tasks, including walking and sit-to-stands, are recommended to promote functional ability in stroke patients by stimulating and regaining motor control. The resistance band knee flexion and extension were implemented to increase lower body strength in a safe way. Both of these exercises are completed seated in a chair, so the risk of falling is low. Gym resistance training program includes machine leg press, heel-toe line walk, step-ups, chest press, high knee march, cable row, one leg standing, and tandem standing. The client indicated poor balance in his timed up and go test and Berg balance scale results. Balance training has therefore been implemented in the supervised resistance training program, which the client will complete once a week in the gym. The balance training includes a heel-toe line walk, high knee march, one leg standing, and tandem standing. Each of these exercises promotes balance, and the one leg and tandem standing have been shown to increase balance and functional ability when combined with gait training. The other exercises in this training session include machine leg press, step-ups, chest press, and cable row. Leg press and lower body resistance training have been shown to promote strength in both the paretic and non-paretic leg and decrease functional limitation and disability. The step-ups were implemented to increase functional ability and develop the strength to complete tasks that may involve stair climbing and lifting the body weight up. The chest press and cable row were implemented to increase general strength of the body and imitate the actions of pushing and pulling daily activities like pushing or pulling to open a door. Aerobic training has been prescribed to this client in the form of stationary pedaling on a mini bike. Aerobic exercise have been shown to improve physiological outcomes in stroke patients, including exercise capacity and blood pressure. Aerobic exercise improves mood and decreases depressive symptoms in those with depression. This form of training has been chosen as the client cannot ambulate for more than 25 meters, so he can safely perform this aerobic training while sitting down. The duration of this exercise has been prescribed in 5-minute bouts, making it possible for the client to continue without giving up.